I'm Associate Professor Andrew Metz. I'm a gastroenterologist and therapeutic endoscopist. When people find out what you do, what's the most common question you are asked? I find it absolutely amazing when I talk about working in the pancreatic space, the number of people who come up to me and say they either have a friend or a family member who's been diagnosed with pancreatic disease recently and really wanting to try and help or donate time or even talk about the issues. It's absolutely overwhelming. How do you tell a patient they have cancer and how difficult is that? I'm always honest. I'll sit down with a patient as soon as we have a diagnosis and go right through the entire story. What we've found, what we need to do next, and what we can do about it, and also the likely outcomes. It's also an amazing amount of information for people to understand in the first instance. So I always say, you're going to forget half of what I'm saying today. I want you to go home, I want you to talk to family, and I want you to write down a whole lot of questions and come back and see me again, because patients really do go into a blur after a diagnosis like that. And I think it's really important to follow up. What's changed in treatment and survival rates in the last 20 years? Well, sadly, in the realm of pancreatic cancer, very little. We know that over the last 20 years, the really treatments and outcomes haven't budged a whole lot. And when you compare this to other cancers that have really come ahead in leaps and bounds, it's a fairly depressing story. It is also exciting because for me, I feel like there is now energy and a quorum of interest around pancreatic research. And I really do feel like over the next decade or two, we have the potential to make some really big gains. Looking at research that's underway, how do you see treatment could change in the future? The thing I'm most excited about is that of early detection and diagnosis. Sadly, pancreatic cancer does not have a screening program, and we often don't pick up on lesions or precancerous lesions that we might be able to intervene in and therefore find things earlier. I'm also hopeful of the future of personalised medicine. We now have the ability as a day case to be able to take biopsies of the pancreatic tumour and do some genetic analysis. And my hope is in the future, we'll be able to personalise treatment based on that patient's cancer analysis. Are there new treatments available at Epworth that aren't yet widely across Australia? Absolutely. Some exciting things at Epworth are now we have a screening program. We also have options for locally advanced disease, that is disease that has spread outside of the pancreas and therefore not operable, but hasn't spread around the body. And there are two new options we have: the nanoknife, destroying cells at surgery, as well as actually implanting radiation treatments directly into the tumour, and with the potential to downstage and improve outcomes and even get these patients to surgery. And that's not widely available anywhere else in Australia. At Epworth now, as an Australia first, we have a full-time dedicated pancreatic nurse educator who's there as the first point of call for patients and their families, helping to direct them in regards to where they need to go next, helping to give education and advice and even a shoulder to cry on. And we strongly believe that this will not only prevent midnight visits to the emergency department, but will also help quality of life and outcomes. What's the one thing about your specialty that you think people would be surprised to hear? Unlike other cancers, which have a lot of media or have campaigns aimed at improving information and improving outcomes, pancreatic cancer hasn't really been thought of as that sexy. And for reasons like that, most people don't even know where the pancreas is. This is a reason that despite the fact that it's predicted to be the second biggest cancer killer in Australia by 2030, only 4% of research funding goes that way. But I'm always overwhelmed every time I tell people I work with the pancreas as to how many people know someone, a friend or a family member, who's been affected by this devastating disease and really keen to help. What are the things that people should avoid to lower their risk? There is no question that a lot of lifestyle activities do impact on the development of pancreatic cancer. Unequivocally, smoking is related and certainly increases the risk. And anyone who's a smoker should talk to their GPs about ways of helping to quit. Obesity is also likely to be a big predictor and another reason why the incidence rates of pancreatic cancer are increasing so dramatically. We also know that 15% of pancreatic cancer has an underlying genetic basis. So looking at patients who have a family risk and potentially getting them into studies for screening and early detection might improve outcomes in the future.